I'd like everyone to welcome or join me in welcoming our presenter today, Dr. Amity Quinn. Many of you will know Amity. She's been part of NOAHE in many guises, I think, for several years now, including being the 2017 NOAHE Fellow from the University of Calgary. She's a health services and health policy researcher and currently a postdoctoral fellow with Dr. Braden Mans and Peter Ferris at the University of Calgary's Cummings School of Medicine. Her research focuses on the supply of health services for people with chronic diseases, including how healthcare is paid for and organized. That's a really interesting topic and very much at the top of the policy agenda at the moment. So today's specific topic is financial incentives and variation in cardiac imaging following initial specialist consultation for chronic heart disease. So before I hand over to Amity, just a couple of housekeeping items. Participants throughout the webinar will be muted. If you'd like to submit any questions during the webinar, please use the Q&A function in the software. And we will hear from Amity and then have a Q&A session at the end for about the final 20 minutes. So we'll get to all the questions at the end. So thank you again for joining us. I now hand over to Dr. Quinn.
Thanks, Jeff. Okay, good job getting that mouthful of a title out. Yeah, but the main things to focus on that we'll be talking about are physician financial incentives and variation in cardiac imaging associated with a new patient visit. So I'm excited to be here today to talk about this project. It's been quite a labor of love for the past year. And for me, and then also for this awesome team I've been working with who got the cohort together while I was on maternity leave. And so I really want to thank my collaborators, Derek, Chu, Flora, Al, Peter Ferris, and Braden, of course, for all of our work on this project. I think it was just about a year ago now, I was planning my return and for maternity leave, and I was supposed to write up a brief memo on our methods approach for this project. And I was like, maybe I need to think more about this. And we spent a lot of time thinking about the methods for this project. And hopefully you guys will be interested in that angle as well as the policy implications. Okay, so to start us off with a quote, this is by Jack Winberg, who's done a lot of research on variation in healthcare in the United States. So, lurking behind variations in patterns of care are often huge hospital investments in expensive technologies that are directly tied to their economic stability. So this quote is really pointing to a lot of his work in variation has identified its supply factors that are really driving healthcare utilization rather than patient demand or patients' clinical needs. And while I recognize there are important differences between healthcare in Canada and the US and in inpatient care, like this quote is about in outpatient care, which we're going to talk about today, this quote still illustrates some of what motivations for this work to help us understand drivers of outpatient utilization for cardiac imaging for new patients in Alberta, and how and doing this work hopefully can inform how to optimize that utilization. Okay, so heart disease has substantial impacts on patients and their families, and the management of heart disease also places a high burden and cost on the healthcare systems in Canada. And in Alberta, about 25 years ago, there was a identified need for outpatient cardiac testing and long wait times for that testing. So there was a conscious policy decision to allow increasing numbers of private cardiac testing facilities to open. So that's part of this, again, is thinking about some supply issues in driving cardiac imaging, but also trying to think about what is the right utilization of that imaging. So, maybe there are long wait times, so we want to increase that, but new international guidelines also state that testing is not needed routinely for low risk patients with acute or stable chest pain. So again, we just want to think about the different factors that are influencing treatment decisions. So there's going to be like the patient factors, like type of heart disease, the risk, comorbidities, physician factors such as like scope of practice and specialty. Maybe they're just kind of like typical patterns of care and beliefs. Site location factors, like what type of imaging equipment might be at a specific site, and policy factors like that would maybe be encouraging the development of additional private facilities. So the objectives of our project were to determine the influence of financial incentives on the use of cardiac imaging for new patients with chronic heart disease, and also to quantify variation in utilization that was driven by physician factors. And just thinking, providing a little more detail on the setting in Alberta specifically. It was in 1998 that the province started released these diagnostic imaging standards and guidelines that allowed for private facilities to offer echo and nuclear testing. As part of that, physicians had to have a special certification in order to interpret those tests and to specifically bill to interpret those tests and to get paid for doing that. So even though these tests are being done in private facilities, they're all paid for by public health insurance, by Alberta Health Insurance Plan. And at this point in 2019, 98% to 100%, depending on the zone, of outpatient imaging were done in privately owned locations. So physicians who are working in these private facilities are typically paid fee for service, and then some of them are also going to have the ability to bill to interpret the imaging tests. So while there's a difference between who's ordering the test and who's doing the test, there's still in these private facilities, there's groups of physicians who are working there, and some of them might be seeing patients, some of them might be doing the imaging, some of them might be doing both patient visits and imaging, and so there's this like sort of shared practice that is likely happening between some physicians who are being paid fee for service and some who are paid fee for service and can also bill for doing the test. Okay, so the data that we used for this project was de-identified Alberta Health administrative data, and the study period we looked at was from April 1st, 2012 to March 31st, 2019. And we linked patient demographic information, physician claims, physician characteristics, and hospitalization data, and created a population-based cohort of adults with suspected or diagnosed chronic heart disease, assessed again at a new visit. So they wouldn't have seen a specialist for heart disease in the past 4 years. And we looked at heart failure, atrial fibrillation, and coronary artery disease, and used administrative data algorithms to identify these conditions. And we, as terms of specialists, we looked both at cardiologists and also internal medicine physicians who were specifically billing for cardiology diagnostic codes. So our primary outcome was the number of nuclear imaging and echocardiography procedures associated with the initial consultation. And we assumed that imaging tests that occurred from 30 days prior to the new visit up to 90 days after the new visit were considered related to that visit. So all of the patients have the same amount of time, this like 4-month window around the visit, to identify our outcome. Okay, so in addition, some other variables that we wanted to look at, because they, again, might be related to the testing that was ordered, are patient, physician, and location characteristics. So for patients, we looked at age, sex, comorbidities, some neighborhood and socioeconomic factors like neighborhood income, urban, rural, proportion of visible minorities in their neighborhood. For physicians, we looked at financial incentives. This is our like main explanatory variable of interest. So that is a 3-category variable that considers both payment model and ability to bill for interpreting imaging tests. So we have salary-based physicians, who also, I think in the results, refer to them as AMHSP, or Academic Medicine and Health Services Program. So they're paid through this alternative payment model. Then they're fee-for-service physicians. And then the third group is fee-for-service physicians who are also interpreters, so they can bill for interpreting the diagnostic tests. We also looked at personal characteristics of physicians, including their age, sex, and country of training, and some clinical characteristics that were defined using physician claims data, like their specialty and clinical workload. And just to make sure it's clear that like these variables are all related to the physician seeing the patient, not the physician who's doing the imaging tests. And then for location, we looked at the physician's primary practice site and the zone that that site was located in. So for our analysis, this is where we've been having so much fun the past year. So first we did just descriptive statistics of patient and physician characteristics by different financial incentives, and looked at to first sort of understand if this variation existed and just kind of explore the variation. We looked at unadjusted patient and physician imaging rates by different characteristics, like plotting it by payment model or physician sex, and just trying to like see if there was systematic variation that we were identifying, and it definitely looked like that. So we decided to use a multi-level modeling approach here. So we have nested general linear mixed effects models. We looked at both 2-level models that had patients nested within physicians, and then also 3-level models of patients nested within physicians, nested within sites. And then for both the 2-level and 3-level models, we looked at 4 different models to try to understand the variation. So both to account for that variation in the model, using the modeling to account for that variation, and also to be able to specifically quantify the amount of variation, and then to understand where the variation was coming from, if it was coming from the patient, the physician, or the site levels. So first we looked at this unconditional model, which includes the physician and or site level random effect, which is a random intercept. And then we moved to model 2, which is adding in physician characteristics, then model 3 adding in patient characteristics, and then model 4 adding in site characteristics. So a lot of the results I'm going to show you today are going to focus on this last model that's like, I'm going to call our fully adjusted model. And then we were able to, in each of these models, like measure again the variation and understand where the variation was coming from. Another approach to being able to understand the variation that we use are creating these funnel plots, which are able to sort of test whether the rate of imaging of a physician's rate of imaging differs significantly from the mean rate across all of the physicians. So we'll see here, it's when I get to them next, you'll see It's like a scatter plot, but then has these confidence limits that do adjust for, well, they do account for the number of patients that a physician is seeing, because we'd assume like physicians who are seeing fewer patients are going to have more variation than physicians who are seeing a higher number of patients. So when we see these plots, like if the physician's mean is falling within the limits, then we probably feel confident that that physician is, maybe they're different from the mean, but that the difference is due to random chance. But if the physician's mean is outside of the confidence limits, then what that is indicating is that the differences are not random, and there's like something going on that's different with that physician that's just not random. Okay, so let's get into some results. Okay, so when we created our cohort, we ended up with just under 32,000 adults with chronic heart disease. Most of them were male from urban areas and over the age of 65. And in terms of the condition that they were seen for at their first visit, about half were for atrial fibrillation, 40% for heart failure, and a smaller percentage for coronary artery disease. And then it was about 9% had more than one condition. Then for the physicians, there were 308 physicians that saw these patients, and 56 were salary-based, 180 were fee-for-service physicians, and 72 were fee-for-service plus interpreters. The mean age was 46 years old, and that was was overall, then also within the different physician types. And they'd all been practicing for about 20 years. The physicians were only 18% female physicians, which I think, is unfortunate, but is pretty consistent with other work I've read in cardiology. And one interesting finding was that overall 63% were trained in Canada, but there was a big difference in training location based on payment model. So about 80% of the salary-based physicians were trained in Canada, or was much lower for the fee-for-service and fee-for-service interpreters. And then location, there are 137 different outpatient sites where these physicians were working, and I was just before this trying to get the breakdown of that by zone for you, but I failed in getting that done. But it's like the most location, the urban areas had a higher number of sites, which I don't think would be surprising. Okay, so when this is just our observed imaging rate, so this is just what we saw initially when we looked at the data. So we can see this top line here is the overall imaging rate across all of the patients for both echo and nuclear tests. And so there were about the 31,685 patients who received 21,321 tests during the study period. So that ends up being about 0.67 tests per patient associated with the new visit. And then that was divided between echoes, and there were more echoes than nuclear. So there was about 0.42 echoes per patient, and then 0.26 nuclear tests per patient. And then here we see the breakdown by financial incentive is pretty eye-opening. So for the salary-based physicians, are ordering much lower or have much lower rates of ordering. So here we see overall the salary-based physicians have patients seeing salary-based physicians have received 0.23 tests, whereas fee-for-service is 0.55, and then fee-for-service interpreters is like coming up close to 1 test per patient that they see. And then we can also see here that the fee-for-service interpreters are seeing the most patients as well. Okay, so jumping into visualizing this variation. So this is a funnel plot of the observed imaging rate. So, and each dot represents a physician, like the mean rate of each physician. So again, and then we're comparing that to the mean, which is that solid line that's at about 0.67. And so just to point out, while we're considering the variation around this mean, that doesn't necessarily indicate if that's like the right mean, should 0.67 tests per patient be the new patient be the rate. So we're not making a judgment on that, but we can see that there, a lot of physicians are falling within within the funnel around that mean. So like a lot of people are just like this would be random variation, or maybe just like expected, we could think expected variation. But then all of these dots that are outside the funnel, both like above the funnel and below the funnel, we would think there's something going on that would be driving that variation. That's just not what we would expect to see by chance. Some other things to point out here that are interesting are, a lot of physicians aren't seeing that many new patients. And again, I think I forgot to mention this, but we did end up excluding physicians who saw fewer than 5 new patients. And when we were doing that, we did explore just like how many patients physicians were seeing, and even physicians who were seeing fewer than 5 patients often were seeing doing many consultations, but they weren't seeing that many new patients. So that's just something to keep in mind, just like what is a physician's capacity to see new patients versus continuing patients, and how that might also impact care delivery and treatment decisions that are being made. So a lot of physicians are seeing a few patients, and then some physicians are seeing more and more, and then there's this pretty substantial outlier who's seeing a lot of quite a high number of new patients. So again, this was over a pretty long period of time. So we should keep that in mind. Okay, so now this slide looks at the risk-adjusted standardized imaging rate for any test, so including both echo and nuclear test, by physician financial incentive. So what I'm showing you here has been fully adjusted for the physician, patient, and site characteristics, but we aren't accounting for the variation. So like the random effects are not accounted for in this modeling. So yeah, so we learned some more interesting information from this. I finally got this to work just yesterday, so I'm even excited just to look at it myself. So I hope I can make you guys excited about it as well. So we can see the red dots are the fee-for-service physicians, the green dots are the salary-based physicians, and the blue dots are the fee-for-service interpreters. So I think it's interesting, there's this I know it's hard to compare to the last slide, but there is like reduced variation after adjusting for these fixed effects, but there still is, we still are seeing some non-random variation, and a lot of that is fee-for-service physicians over here, and then these fee-for-service interpreters here. I think it's also interesting to consider that the fee-for-service interpreters are just more spread out in general, like they're not all clumped they're not all clumped over here like the fee-for-service and salary-based physicians. And then, you know, with some exceptions, it does seem like the fee-for-service interpreters are seeing more patients per physician, which that sort of lines up with what we had noted earlier, which is just the fee-for-service interpreters are seeing more new physicians than the other types of payment models. Okay, so then to try to help us understand the variation more, what we also can find out from the modeling is how much variation there is and where that variation can be attributed to. So this is for all tests of both the echo and nuclear combined. And then we move from, so I'm showing you results from different models, the unconditional 2-level model, and what that includes just a random effect for the physician. Then we move to the unconditional model that includes, that's for the, and then the additional models that are for the 3-level models. So in what these results tell us, the marginal expectation is like the mean imaging rate accounting for the random effects. And then what the marginal variance is telling us is if it's higher than the marginal expectation, then that is indicating that there is clustering at the physician and or site level. And then this site, physician, and patient VPC, which is a variation partition coefficient, that is the proportion of that marginal variance that is explained by that specific cluster. So between, or at the patient level, would be like within the clusters. So what does that mean here? So if we just look at the unconditional 2-level model, and when we ran that, we see there is, you know, there is clustering happening at the physician level, which tells us using this type of modeling is appropriate. And then we can see that 25% of that variation is due to physician factors. So that seems pretty substantial. But because as I had mentioned in the introduction, like these physicians tend to be like working in a group practice at these private clinics, we like really wanted to think about the effect of site. So we included this site level random effect as well. And when we did that, you can see the mean actually goes up, but there's still, the variation also goes up. And then we, like 10% of that variation is due to the site level, and then 14% is due to the physician level. So it doesn't really change what's happening within the clusters at the patient level, but we can see by going from the 2-level to 3-level of unconditional model that some of that large 25% of physician variation is definitely partially explained by the site level. Okay, so then in the next model, we add physician fixed effects, including the financial incentives, their age, and specialty, and I think something else that I'm blanking on, but anyway, when we do that, it doesn't really change the mean. It like slightly reduces the variation, and then does reduce the amount of variation due to the site and physician level a little bit. Then we add patient characteristics, and it doesn't really change anything here substantially. And then when we add the site characteristics, which was just a zone, and that explains, that does reduce the variation, and then reduces the variation by the effect of site and physician. So more of the variation that we're seeing then is really within the patients. Okay, so this reference, if you're interested in this type of stuff, this references to a paper that talks about how to quantify these variance partition coefficients for negative binomial models. Okay, and then so taking that fully adjusted model at the end, that it includes both physician and site random effects and the physician site patient fixed effects. We can also look at this, how the variation compares across between the echo and the nuclear testing. So this any test result is what you just saw on the previous screen. But what I really wanted to highlight here is the difference between the echo and the nuclear testing. It's pretty substantial. So the echo marginal expectation is 0.42, which is what we had seen in the observed rate, and the variation is pretty close to that. So there's not a lot of clustering happening. There's, as we see here, the variation that does exist, a very small proportion of it is due to the site and physician level factors. Only 2% are for the physician level factors. And a lot of the variation is accounted for at the patient level, which would indicate that like the echoes are being done more based on patient needs or patient factors. In nuclear, we see the marginal expectation is 0.34, and then there's a lot of variation around here. So I'm not showing you all of the results here. There is a lot of over dispersion in this model, and we know that there's just a lower number of nuclear tests, so we kind of expect more variation. But still, like from understanding the variation that exists, 20% of it is due to these physician factors. So that was pretty, well, like, so there's this huge difference in like the physician effects between the echo and the nuclear testing. Okay, so then turning to our fixed effects and away from looking at our variation and random effects, we see, like, I mean, we already had looked at the observed rate, but even after adjusting for all of these patient, physician, and site characteristics, we see that the incidence rate ratio for fee-for-service to salary basis is over 2, and then for fee-for-service interpreter compared to salary is close to 3, and that's a little bit higher for nuclear testing than echo testing. So this is a pretty, substantial increase in the test ordering rate by financial incentive. And then if we look at the zone fixed effects, I mean, one takeaway, so this is zone 1 is an urban zone, and zone 3 is a different urban zone, and then 2, 4, and 5 are both more rural areas. So in general, like we're seeing here, there's not that many significant effects that we're observing, but like it makes sense, I think, that there'd be less testing in the more rural areas, and there's more testing in the urban areas. But what I wanted to highlight here is that for nuclear testing, there's almost a 70% increase in zone 1 compared to zone 3. Okay, so in summary, we see significant variation in use of cardiac testing at these new patient visits, and physicians and sites are clearly playing an important role when we're studying these imaging rates. And when we adjusted for patient fixed effects, there was minimal effect on variation, which again suggests the differences in the imaging rates between patients who are seeing different physicians at different sites is not primarily being driven by differences in clinical need. It looks like it's being more driven by physician and site characteristics, or maybe especially physician characteristics in the case of the nuclear testing. So, when we adjust for these fixed effects, in random effects, we are seeing a reduction in the variation for overall and for echoes, but there is the substantial variation that remains in nuclear testing even after adjusting. Clearly, financial incentives are heavily influencing the imaging rate, and they're significantly associated with that. And as we saw, there was this 70% increase in the rate of nuclear testing between the different zones, urban zones. So to compare our findings with other research, yes, a lot of studies have found fee-for-service is associated with higher utilization. There's also some of the research on variation from the US, specifically looking at cardiac facilities that identified just like the location and number of cardiac facilities being associated with like them existing in this area is associated with higher utilization. So that's similar to what we're seeing here. And then how these imaging rates compare to Ontario. A recent study that looked at patients with heart failure found that the rest, similar to us, that like echo and nuclear testing are the most commonly used non-invasive tests, and they found a rate of 0.5 echoes per patient, and then 0.07 MPIs per patient. So that echo rate is close to what we found, which is 0.42. We looked at both MPIs and MUGA, so two different types of nuclear tests. When we looked at the rates of those two different types of tests separately, they were pretty similar. So if we assume that, then like the rate of nuclear testing that might be happening in Ontario might be about 0.14. So that falls sort of between the salary-based rate and the fee-for-service rate that we're seeing in Alberta, but it's a lot lower than the fee-for-service interpreter rate. And then there's also a study in Alberta in Ontario that looked at the total population for nuclear imaging and then found so this is not just specific to people with heart disease or new heart disease, and they found a rate of 0.025 nuclear imaging tests per person. So we also wanted to just see if what we were seeing for new patients, how that compared to the population rate in Alberta. So what I'm showing you here is age and sex adjusted outpatient imaging rate for the whole Alberta population by zone for both echo and nuclear. So we see that in zone 1, there's a higher rate of both of these types of tests, and definitely the highest rate of the nuclear testing, which makes sense. Cool. That's what we found for new patients. So that's also the pattern at the population level. Okay, and then thinking more about like the role of patient, provider, and location factors in making treatment decisions. I'm really interested in this area of research and in looking at it and just trying to understand what are different methods to measure and account for and visualize this variation in treatment decisions and care delivery. So the studies in this area like do a lot of different things, and there's new work coming out all the time. Like that methods paper I mentioned just came out in the past couple of years. So there's like doing multi-level modeling is maybe is a common approach. There's not it's not hard to always it is hard to compare the results from these different variation studies because they're using like such different methods. So just a couple of studies to compare and thinking about these different factors in making treatment decisions. In a paper that was about when to initiate dialysis care, they identified that less than 10% of the variation in in when to initiate dialysis, and when dialysis was initiated was due to facility and geographic factors. And after adjusting for fixed effects, it explained 7% of this variation. So those authors concluded that the treatment decisions for starting dialysis do appear to be driven by patients in their clinical need. Another study that looked at the provision of a range of low value services found that when I couldn't quite understand the quantity of the variation that they found in the first place, but when they tried to adjust for physician characteristics, it didn't account. It accounted for about 4% of the variation, and based on their findings, that was a very small amount. They decided that was a very small amount of the variation. And made the conclusion that the treatment decisions around these low value services were not being driven by clinical need. So that's just to say there might be, in different specialties or different types of services, like dialysis versus a low value service, like what are their characteristics of the service itself, or like the level of need or risk that a patient has for like a life sustaining therapy versus like a more low value service. Like there might be different factors going into those decision making processes. Okay, so there are a few limitations of our study that I wanted to highlight. First of all, we don't explicitly know if the specialist who saw the patient for their new visit is the physician who ordered the test. And we could imagine there are intentionally different types of people who are sent to fee-for-service interpreter doctors that we can't measure, maybe like referral patterns or issues with wait times, or as I had mentioned, just like the availability to see new patients. And then lastly, we can't know about the appropriateness of these tests. But one thing to think about is that if they were all appropriate, we'd expect all the different types of physicians to order the same number per patient. Okay, so thinking about what this all means, we first had some more uncontroversial policy implications. So we could think about making policy and practice changes to support patient-centered imaging decisions. And maybe one way to do that would be having clinical decision pathways that would reduce the influence of physician insight factors on utilization. So also some additional research looking at the appropriateness of testing would definitely be important to help us understand what the actual ideal imaging rate for these patients would be. And then we could think about the utility of funnel plots for doing physician audit and feedback, or some sort of site audit and feedback, maybe, or to look at changes that resulted from the clinical decision pathway, for example. And since these are ways to sort of compare performance without ranking. Some more controversial things to maybe think about, and I'd be happy to hear your thoughts in the question and answer time, or please feel free to email me or reach out to me after, would be, what do we do about the huge effect of financial incentives on this testing? And one thought was could there be some sort of other underlying characteristics of the physician, like not the payment model itself, like reasons why the physician is choosing that payment model that might affect it? Like I did find the physician sex, age, and specialty were not significantly associated with imaging rates. So I don't know, so some research on physician variation has just found, I guess, more qualitatively that like physicians' beliefs are sort of, like what they usually do is what they keep doing, or misunderstandings of clinical risk or need, for example, or also areas where there's like uncertainty in what sort of what's clinically appropriate, are also can be challenging areas for treatment decision making. So anyway, but what could be the policy response to these financial incentive effects? Another question is like, so we're seeing this much higher nuclear testing rate in this one zone. What could be the policy response to that? So two potential thoughts would be a physician level intervention that screens all testing referrals for appropriateness, or, it's, as we've seen, there's both physician and site level factors that are having an effect here. So, I mean, could there also be a site level intervention, such as doing an audit as part of a facility accreditation? So thank you very much, and I'm happy to take questions now.
Great, thanks so much, Amity. Really interesting. Sorry, excuse me. Really interesting talk, and there's a couple of questions already in the chat box. If anybody else has them, I will read them out to Amity, so she doesn't have to try and triple task here. So the first one is it's from Kenna Brown. Apologies if I've mispronounced that. It says, thank you for your talk. This is very interesting data. Can you postulate why fee-for-service interpreters are seeing so many more new consults versus fee-for-service physicians? And I think you did start to get into that a little bit, but the difference seems to be more than I would expect based on remuneration rates, but I may be wrong.
Yeah, that's a really good question. I haven't had that much time. I just I just did run that, got that plot working yesterday. So I think that's an interesting question. Like, yeah, like why, like they're being paid the same amount for the consult itself. So like, are there just, I don't know. And maybe I mean, like you'd think both types would want to see more patients. I mean, just like theoretically, you'd want to see more patients to be able to bill more. So like, yeah, the rate there, you'd think for the visit itself would be closer. I don't know if it has to do with the location. Again, maybe it's a location factor. Like maybe there are more fee-for-service physicians working in like public facilities, whereas the fee-for-service interpreters are more seeing patients in the private facilities and are just because of the way that they're organized, are able to get more patients in those private offices. So I'm not sure if anybody else has any thoughts. Please feel free to add them in the chat box.
Okay, thank you. The next question is from DJ. Was there any consideration in pairing outcome data with this work? Either have you done that, or are you planning to, I guess?
We have not done it, but definitely are interested in doing it. We're both interested in connecting this with outcomes, and then also looking at sort of the treatment cascade, like what happens if like after this potentially low value imaging is being ordered, since other research indicates that like that we might be seeing like continued overuse of cardiac services. So look forward to that in future talks. Yeah. Thanks, DJ.
Great, thanks. Are there any other questions that people like to put into the chat box? There's the chat box as well. Follow up from the first question. Great thoughts, thank you. The theory of fee-for-service interpreters working primarily at sites that allow for higher patient throughput makes sense to them. So perhaps that's something to explore in a little further detail. Any other questions while we wait? I mean, I guess, and apologies if you said so, but you know, what are the next steps that, as you take this forward?
Yeah, so sorry if I'm repeating myself a bit, but yeah, so we're interested in looking next at sort of what happens to these patients after these new visits. And what I'm really interested in doing is looking sort of at the sequence of care, not just like all of their utilization in a year and like in buckets, but kind of, yeah, what is the sequence of care that they get? And again, trying to connect that also with costs and maybe identifying sort of patterns within those sequences that might and how they're associated with costs, and maybe try to identify again, what we wouldn't really understand appropriateness through that, but to maybe try to identify what are the most like efficient care pathways, and then connecting those again with outcomes to see if we can understand like which pathways are associated with improved outcomes. Another strain of work we're interested in doing is like understanding, doing a scoping review of methods to measure and account for and illustrate variation in care. Well, you know, again, as I had mentioned, there has been a lot of work in this area, but there's new methods coming out all the time. So I'm interested in things that I showed you today, and also like maybe machine learning type approaches that would help in identifying those sequences of care that I'm interested in finding. And then our dream, is to understand the appropriateness, but maybe we can figure out how to link to data that would tell us about that, but we haven't gone down that road yet.
Yeah, that's a super challenging task when appropriateness is so subjective. Mm-hmm. But I know it's an important consideration at the moment, and a lot of people are very interested in reducing inappropriate care, not just on grounds of cost, but because it's sending people for tests they don't need and putting them through procedures they don't necessarily need. So it's an important clinical as well as system level question.
Yeah, exactly.
So the chat box is also reminding us to sign up for the next rounds. We've only got a few minutes left on this session anyway. So I want to thank Amity for her presentation. Please do follow up either with her and the address on the screen if you have any further questions, or you can feel free to email the NOAHE address if you prefer, and we can put you in touch. The next rounds will be January 19th, 2022. Value-based decision-making, panacea or deja vu, presented by Andy Chuck from AHS. So I hope you all tune in again for that one. If we could, I mean, we can't clap for Amity. I can clap. I suppose the applause of one person over a microphone would almost be more dispiriting than anything, so I won't. But thank you, Amity. I appreciate it. I hope everyone has a relaxing and pleasant break over the next few weeks, if you do. And we'll see you all back here in January. Thank you.
Thanks, everybody. Happy holidays.